Here, we'll request Dr. Pradeep Poswal, an anesthetist in the Delhi Heart and Lung Institute, to moderate the next session. And we have Dr. Praveen Khilnani, What's New in Critical Care. And ladies and gentlemen, I just introduced you to Dr. Subramaniam, and Dr. Khilnani is another one who is going to perform live from 6 o'clock onwards here. He is, अगर ये critical care में नहीं होते तो शायद country में ये medical singer होते. So he is going to run the show of the cultural evening, and we'll also have a pop singer with us, Vipin Aneja, to whom we have called, and the function will start immediately after this session. We will have a award session followed by the cultural program. I request Dr. Poswal to introduce the speaker and start the proceedings.
Good afternoon. Thank you, Dr. K.K. Agarwal, to give a good opportunity to me. And Dr. Praveen Khilnani, he is graduate from Maulana Azad Medical College and MD Anesthesia from All India Institute of Medical Sciences. Trained in ICU at Harvard University, USA, set up Apollo Hospital, Pediatric ICU in 1998. Now senior consultant at Max Healthcare, Chairman Indian Society of Critical Care, Delhi. Dr. Praveen.
Thank you. First of all, I'd like to thank the organizers over here to invite me to share some of the views, because critical care is a relatively new field, and in the past decade there have been lots of changes, and lots of those are being applied in India here also. Coming straight to the point, what we have seen in the past 10 years is there are international surviving sepsis guidelines that have been recently published in 2008, initially published in 2003, because sepsis is a very, very common condition both in adults and pediatrics, and it's always a big problem in talking about whether it is infection, septicemia, sick child, what's going on. So lots of these definitions and guidelines have been standardized. Gist of it is, if you give early empirical antibiotics within the first hour of presentation, it makes a difference. So sometimes we get busy in resuscitation and forget the antibiotics, so it's important to get that in. Activated protein C, more so for adults who are very critically ill with sepsis, could be considered. In children, however, there is a problem. There were some incidences of intracranial bleed, so that's why it's not being recommended for children. And infection control, the good old hand washing, has been re-emphasized. And I think it does not take a hi-fi ICU to be able to enforce hand washing. Transfusion. We have heard lots of risk about it. Transfusion risk and morbidity has been emphasized, and now the transfusion threshold in critically ill has been reduced to 7, and this is pediatrics and adults alike. So don't take transfusion lightly. Other thing that has come up in critical care is high glucose is bad. You know, in pediatrics neonates, we always say low glucose is bad. We know that the low glucose can cause problem, but in the past decade, now we have become very familiar that you cannot have stress-related hyperglycemia linger on for a long time and try to use dextrose-containing fluids. So normal saline, ringer lactate, those are still the fluids recommended. And there are strategies to prevent control hyperglycemia. And then regarding the ventilation, what we have seen now is when you have a very critically ill patient who has ARDS, we use low tidal volumes. Low tidal volumes being 5 to 7 ml per kg rather than 10 to 15 ml per kg. Why? We want to reduce the ventilator-induced lung injury, as well as try to extubate early, increasing the use of non-invasive ventilation now, so that incidence of ventilator-acquired pneumonias can also be minimized. Percutaneous bedside tracheostomy has come up now, and intensivists are performing bedside tracheostomy under a bronchoscopic view. High-frequency ventilation is one more technology I think that has been very promising, came from the neonatal literature, pediatrics, but now is being increasingly used in adults, which minimizes the mean airway pressure or the peak airway pressure, so therefore lung injury, which is because of conventional ventilation, tends to get minimized, especially in patients who have bronchopleural fistula, air leak, pulmonary hemorrhage, or very, very severe hypoxemic failure. So the biggest thing that has come out in the past 5 years is an article by Dr. Rivers, which was in New England Medical Journal, talked about early goal-directed therapy. You know, you don't try to fix the patient right away. Make short-term goals in a septic patient. Try to do some interventions to achieve some temporary endpoints, out of which fluid resuscitation is very important. Isotonic fluids, doesn't have to worry about colloids. You can use crystalloids, and they are to be used before inotropes. Early use of dobutamine and norepinephrine in septic shock, and then titrate the therapy according to short-term clinical goals. And the mixed venous oxygen saturation, which is a relatively new concept, easy to do. You don't have to put a Swan-Ganz catheter to get an approximation of the oxygen delivery now. You can have a central line, or even a peripheral venous saturation can indicate what's the status of oxygenation. Mixed venous saturation to be kept more than 70 pretty much tells you that your oxygen delivery is good. So the more of the therapy has been delivery oriented. And then there are American College of Critical Care Medicine recommendations for sepsis. We in Indian Academy of Pediatrics also came up with a consensus which has been now internationally accepted to how to take care of a septic shock patient in resource-limited environments, where through the peripheral IV, things like dopamine up to 10 microgram per kg are allowed until a central line can be placed. So there are time-bound guidelines, 0 to 60 minutes, golden hour of sepsis management. Those guidelines have come up now. And other thing that is very, very increasingly, and if you are seeing the critical care conference programs now, ultrasound in the hand of intensivists, not necessarily the radiologist, but intensivists, to basically be able to do echocardiography as bedside tool to assess the poor contractility, rule out effusion, pleural effusion, pulmonary atelectasis, and try to get central venous or arterial access under ultrasound guidance. And there are portable ultrasounds available. You're going to see that more and more. In resuscitation, we now talk about epinephrine or adrenaline as a universal resuscitation drug in cardiac arrest. 30 compressions to 2 breaths as a universal CPR recommendation, whether it's a child or adult. Use of hypothermia in cardiac arrest and asphyxia, that's still in research, but it's coming up. And then automatic external defibrillators, AEDs, to be made available publicly. And I think that is much more of a government initiative now, with Commonwealth Games coming up, that such resuscitations be made available with public training, firefighters, police training. Cardiac critical care, I won't go much into. You very well know we do early PTCA and thrombolysis. There are left ventricle and biventricular assist devices available now in critical care areas. And of course, as a bridge to possible heart transplant. And heart transplant is not universally available, but it's coming up. In neuro, we are doing CPP guided therapy, which is cerebral perfusion pressure. And what we have seen now is hypertonic saline is being used for ICP management. Other thing that has come up is factor 7A for uncontrolled bleeding of any non-specific cause while the cause